Welcome to Intended Consequences, the official podcast of the Strategy Corp Institute of Public Policy and Economy. I'm your host, Mitch Davidson. Today, we're joined by the CEO of the Ontario Long-Term Care Association, Donna Duncan. The OLTCA, as it's known, represents 70% of the province's long-term care homes, which include private, municipal, charitable, and not-for-profit home operators. Together, those 70% of members care for over 70,000 residents a year. Donna, thanks for coming on the program to talk about long-term care today.
Thanks, Mitch. I'm glad to be able to join you.
Yeah, so let's jump right into it. Obviously, it's been a difficult year for long-term care and for the healthcare sector in generally with the COVID-19 pandemic, and particularly for residents themselves. In Ontario, just to set the table here a little bit for our conversation, there's been some 6,000 long-term care patients that have been infected with COVID-19 at some point, and sadly, over about 1,800 of them have passed. Recent studies have suggested that as many as 30% of the province's COVID-related deaths have come from long-term care facilities. And obviously, there's been a few particular instances where the military or hospitals have had to step in to help oversee some of the operations in some of the worser performing homes. So let's just start with a very basic question, given that sort of synopsis and what's happened. Why were Ontario's long-term care homes hit by the COVID pandemic in the way that they were?
No, it's a question, certainly, Mitch, that we've been reflecting on, and you're right. It was a really tough year, and it started back in January, February, when we were presenting to the Ontario Legislative Committee for Finance and Economic Affairs with our pre-budget submission, where we said we were facing a perfect storm. We started out with an HR shortage in the sector. We knew that we were providing care in buildings that were 50 years out of date with 3 and 4 bedrooms. We knew that we struggled with the funding and how the funding wasn't built to support an HR model that actually supported the care needs of the residents we have today, who have very, very complex needs. And I think it's important too to remind ourselves this is a global pandemic. And I think at times in Ontario, we lost sight of that, where the focus was so much on what was going wrong in long-term care in Ontario, when in discussions that I was having with my global colleagues, even in January, my colleagues in Spain and Italy and the UK, what was unfolding in our planning in Ontario actually mirrored exactly what was happening in those countries as we were starting to see the media really unfold and showing the horror stories about what were happening in care homes and to people who were living in long-term care, not around the world before it even got here. And so the prioritization of hospitals over long-term care, especially when the predictors would have said that, we were looking for a hospital surge. So much energy was being invested in planning for respirators for hospitals and enhancing and building out field hospitals to build hospital capacity. And in fact, for long-term care, notwithstanding, the state in January, we were being turned to where the government was saying, can you find extra space so you can just squeeze in a few more people from hospitals so we could expand hospital capacity? I think what went right in retrospect is we didn't have the hospital surge in Ontario. And thankfully, thank heavens, people social distance and we took it seriously. At great cost, though, certainly clamped down on visitation. We put that iron ring around early. And I think that certainly proved to help. But, we still had, out of our 626 homes, we had about 30 homes in the province who ended up in a crisis situation. 80% of the homes in long-term care, the story no one tells, 80% of the homes had absolutely no deaths. The majority of homes had no outbreaks at all. And so there are some good news stories in here that we weathered. And certainly where we saw the worst losses, it really was their own perfect storm in themselves. So those outbreaks where we had those really tragic, horrific losses, those were homes where the outbreaks happened early on, where we didn't yet know about asymptomatic spread. We were still learning, and this shape-shifting invisible beast was moving through the homes, and we didn't fully know what it was. Then we had so the timing mattered for those homes. Certainly, what also mattered was the age of the homes. If you were a 3 and 4 bed home, if you were certainly in a hot spot, and we saw those hot spots early on was where they had asymptomatic spread, people traveling, and then later on we saw them in the urban centers, and certainly Toronto, Peel, Ottawa were hard hit. So it wasn't one thing that made it happen. It was all of those conditions together. And we do know, too, that in those early outbreaks, as soon as they got their first negative or positive case, staff left. Staff were afraid. They were afraid for their families. They were afraid for themselves. Certainly, the media about what was unfolding in Europe mattered. The media coverage in Canada mattered. And that had a huge impact on staffing levels and the ability of homes to manage that.
Yeah, I mean, I think, you made a lot of points there about the particular different circumstances that combine to lead to this. But one of the ones that you mentioned, which I think is an interesting one that doesn't really get talked about a lot, is the complexity of the patients, right? So, it strikes me that it's more difficult to contain a virus when you have patients who need to be checked on regularly, patients who may not be fully aware of their surroundings, who may have cognitive impairment of some sort. I mean, I have some of the statistics here that say that, for example, as many as 90% of patients have some form of cognitive impairment in Ontario's long-term care homes. 76% have heart conditions, and six out of every 10 take 10 or more different prescription medications. So all of those things to me say that you've got a patient base that requires a lot of care, and if you have staff who are fearful for their own personal positions and may not show up to work or may not feel safe in their surroundings, that can find itself to become a very difficult situation very quickly. So how does the complexity of the patients really sort of coincide with the difficulty of preventing this virus from spreading within homes?
Well, and it's so interesting when you think about the public policy decisions that were made over the years that impacted this and the profile of who our residents are. And to your point, they are more patients. These are the alternate level of stay patients from hospitals who couldn't go home. People do not choose to go and live in long-term care. People go there because their families no longer have the capacity to care for them at home, or they can't be cared for in hospital. And so these are homes. This is longer stay care, though the average length of stay is closer to 2 years now. Certainly, when the government of the day was looking at the long-term care legislation back in 2007, they were building for a different population. The objective was, we want home care. We're going to prioritize home care, and everyone's going to age in place. Unfortunately, the reality is, or fortunately, people are living longer, but they're living longer with far more complex needs and a lot of coexisting health issues that, as they get older, make it very difficult for a family to care for them in their home environment. So it's, and we know, as certainly the data now show us that those who are most vulnerable worldwide, not just in Ontario, to dying from COVID-19 were people over the age of 80. And these are the majority of people who are living in our long-term care homes. And even as we think about our future state and the measures that we're going to have to put in place to support our aging population, we know that over the next 13 years, the population in Ontario over the age of 80 is going to double. And so, we've got a collective responsibility to acknowledge who our patients are. And I think we struggled a lot, quite honestly, with stigma in that families feel guilty when they can no longer look after their loved ones at home. I know I did when my mother and I had to make a difficult decision about placing my father in long-term care a number of years ago. We struggled with that. And so people didn't want to talk about it. And in many cases, we accept it. And I think what we've been through, if there's some good that has to come out of this, and it has to, because these lives can't have been lost in vain. We have a moral duty and an obligation to do better for our seniors, and we need to fix this. And I think that's going to be a tough one, because it's not easy.
Okay, so let's talk about that next step, because it does seem to me that two of the better defenses that we've put in place as a society against the virus are social distancing and frequent hand washing and sanitizing. And if you have cognitive impairment, you may not remember to do that on a daily basis. And if you need assistance feeding, clothing, bathing, you can't really social distance. So it's a very difficult work environment, a very difficult setting to use these common defenses that we've been unleashing against the virus as a society. So I think that complexity is a really important point to underline. But you mentioned, what do we do next? How do we move forwards? How do we make sure that we improve the situation, both in those particular long-term care homes where there were obviously outbreaks, but across the system writ large, to make sure that this doesn't happen in the same capacity or way that it happened before? So obviously, the Ontario government is not news to you or to me, but they've announced that they're doing a sort of investigative commission into the state of long-term care and what happened during the pandemic. But that report may not be available till as late as April of 2021, I think, is the timeline they put out. So what steps do you take in the meantime? What do you do next as the Ontario Long-Term Care Association, and how do we make sure that we are better prepared?
Well, I think we have a collective responsibility to act this time. And unfortunately, because long-term care was outside of the healthcare system, that complicated matters. And we now have relationships and partnerships with the healthcare system, including hospitals, that we never had before. And I think certainly a better working relationship between the Ministry of Health and the Ministry of Long-Term Care. And that will be better. We know what worked. We know, if you look at the calendar, we know that on April 15th, when the government introduced its action plan to support long-term care, that was when the losses in long-term care peaked. And then there was a steep, sharp decline immediately after that, because the prioritization of personal protective equipment worked. Because prioritization of universal testing for staff and testing of residents in long-term care worked. So we're certainly big proponents of continuing those prioritizations, especially with less invasive tests for residents and staff. But we know those things worked. The partnerships with hospitals were great stabilizers. Certainly, as an association, we've been advocating since May. Immediately once we realized what was working, let's continue with those things, but then let's also enhance the infection prevention and control capacity inside the home. We know that homes dealt with the flu in the past, but this shapeshifter was no match for the measures that long-term care homes, together with public health, would have used for regular flu outbreaks. So let's enhance that capacity and not let up on that. Let's build that over the coming months. We've lost some months on that, quite honestly, in terms of getting that in-house. But I think with partnerships with hospitals and others in the community, I think we can start to reinforce that and build it up through the fall. We need physicians on site. We know that we didn't have as much physician presence, and I think there are some quick fixes that we can do in working with our doctors, our medical directors, to provide oversight and support in the homes that will give staff and others safety. I think if we're going to get staff in and keep our staff and make families feel safe and residents feel safe, we need more robust sort of wraparound. And we need to deal with some retrofit issues on the physical plant. We've heard, certainly with school boards, they've been fixing the HVAC systems and the airflow. We know that some of the issues that we had in these older homes in particular, we know that upholstered furniture was not helpful for infection prevention. So what are some of those investments that we need to do immediately and deal with those? And we need to, we know that for the longer term, we need to move forward more aggressively with the capital redevelopment program. We know that for this fall, when we started in January, there were 36,000 people on the wait list for long-term care. Today there are 38,000 people. And we know that if we're not going to have 3 and 4 people in a room over the fall, that's going to take out another about 4,500 beds out of the system. And we know that hospitals are already at capacity.
Yeah.
We've got work to do.
Yeah. I mean, I actually wanted to build on that point because the comparison to schools is an interesting one, right? I mean, I think there's been a lot of media attention, obviously, with schools coming back in early September here. About how many you could fit in a classroom, how many students you could fit in a classroom, what that would look like. And I don't think that same conversation has necessarily been paid due diligence on the long-term care side. So you mentioned, interesting, that in some facilities there are 3 or 4 patients per bed. But if you want to keep those, or per room rather, if you want to keep those restrictions in terms of how many people in a room, you're going to need more capacity in a system that's already at capacity or over capacity given the wait list. So I think that's a really interesting point that makes us think about the way that we do long-term care moving forwards. And as recently as last year, I know the financial accountability officer in the province came out and said just to maintain the wait list where it was in 2019, you'd have to build some 55,000 new beds by 2033, just to keep the wait list where it was already at because of the aging population and the amount of people that will be looking for long-term care. So knowing that, and knowing that the province has put up, I think, about $1.5 billion to help build some beds faster under a new funding model, what do you do to get new capacity online and new beds online, and what is being done, and frankly, is it working?
So the government recently made some announcements. There are some new partnerships with hospitals in the GTA that are going to help. They've made some announcements. Certainly, we have a number of members who are now out in consultation process for redevelopment. It's a start. Certainly, the capital redevelopment program has been a challenge from day one, and hasn't been especially transparent. It's very complicated. We know that one of the barriers that we're experiencing right now in order to make sure that we can redevelop is we need to make sure that we can get financing. And one of the challenges with legal actions and such, we're certainly hearing that a number of homes are struggling to get financing because of the issues around lawsuits and risk, which is a new barrier for us that we weren't facing in January when we were advocating for a new development process. This is going to take all 3 levels of government working together. The federal government has a track record for investing in infrastructure and supporting provinces with that. We think that if we are going to meet the needs of our future population, let alone today's population, we need federal support to expedite this. It's going to take resources. You invest in what you value. We need to demonstrate that we value our seniors. These are people who built our communities. They built our families. And we need to make it a priority and not talk about why things can't happen, but need to work together about how. Certainly the municipal government plays a huge role in planning processes and zoning and approvals. And there are layers and layers of bureaucracy. We're certainly concerned that as these processes are rolling out with the provincial government right now, we're mapping against a municipal and a provincial election cycle. And we know that in those cycles, these approval processes stall. So how do we make sure that we have a very transparent process about where these things are going to be built, how those choices are going to be made, what's going to be built? Let's not just have cookie cutters. Let's look at campuses of care and more innovative models. Let's look at creative partnerships as well. But let's make sure that we have a very clear and simplified roadmap for the path forward. It's going to take discipline, but it is going to take all 3 levels of government to make it happen.
Yeah, that's a really interesting point, because I don't think most people would realize the sort of interrelation between provincial and municipal levels of government when it comes to building these things. I mean, there's obviously a provincial ministry of long-term care. So when you think about building a new bed, that might be the place that you think about. But in reality, there's a lot of municipal approvals. And I know the province has done some new innovative things. They got a new modular build process with Infrastructure Ontario. And I think they're using some provincial lands to help sort of fast track that process, from my understanding. I mean, these seem to me like good steps, but not necessarily enough to fill the sort of 55,000 bed void. But as you mentioned, it takes all sorts of different solutions and different approaches from different governments.
Well, and absolutely. And the city of Toronto, we're still dealing with land values and access to land as well as affordable land. And, one thing I would point out too, I've certainly been asked a number of times. So you have for-profit members. Why didn't they just go and rebuild? I don't think there's an appreciation for just how strictly controlled the redevelopment and development process for long-term care is in the province. The government controls the licenses. They guarantee licenses for certain times. You have to have development agreements where the government sets out what you're going to build, how many beds you're going to build, because the government controls how many beds are actually operating in the system. So as much as anyone would have liked to have gone to redevelop, without the assurances and the agreement with the government to redevelop or develop and build in a certain format and what are the design guidelines and guarantee that you're actually going to have licenses, both for-profit and non-profit homes, to secure financing up front, required those assurances. And that was controlled by government from day one.
Yeah, I think that's a really good insight because, obviously in my past job in the Premier's office and in opposition, you've got a lot of questions about how you're going to fund long-term care, right? I think all three political parties in the 2018 election made big promises about building new beds, and they had to put money aside for that because the government funds a per diem per patient. And so it's not private in the sense that, you're charging whatever the free market wants you to charge. It's very much a government control, but private in the sense that there is an operator who makes a profit instead of a not-for-profit or a municipal run home. So it is a distinction worth noting because I think it's really important. And to me, when we talk about that, so this is actually, a great segue because there were two things I wanted to talk about when we do talk about bed expansion and new builds. Two real points of differentiation for me. And the first one here is the ownership model, right? So OLTCA, as we mentioned off the top, represents private, non-for-profit, charitable, and municipally run homes. So there's been a lot of criticism during the pandemic, specifically about homes in private ownership and private operation, where some of the worst outbreaks occurred. Why do you think that those homes have had a tougher time? Or is that frankly the case, or is that just a perception that we've got right now? So what's the situation going on with the private ownership specifically?
Yeah, I would say that it's a perception issue. So the majority of homes in the province of Ontario are private. A minority of homes are municipal, and then a minority are also charitable homes. And so just by virtue of the majority of homes, you will have a correlation to prevalence. But, we've crunched the data. We've certainly looked at data in across the ownership models, and ownership is not the problem. Even Dr. Stahl from Mount Sinai, who's co-authored a paper, said that the underlying finding was that ownership was not a factor in these outbreaks. It really was a matter of the co-occurrence of those elements of the perfect storm around staffing, the timing of the outbreak. Was it early on before we knew about asymptomatic spread? Was it in a hotspot? Were you in a local community where there was a lot of social spread? Those things, and combined with the old buildings with the 3 and 4 bedrooms that were at capacity, those really were the root causes. But there were those elements that all happened together. So it was that perfect confluence that really was underlying. So as we look at our ownership, the question we always say, what is the problem that we're trying to solve for? And, what I struggle with as I started off talking about this is a global issue, and there are lots of trends and that we could, and themes that we saw as this crossed the world, that are not unique to Ontario, including ownership models. How do we make sure that we're valuing our seniors? How are we investing in them? How are we sharing accountability for the fact that collectively we needed to have done better and we didn't? We need to celebrate where we saw success. understand the successes as much as the failures, and ensure that this never actually happens again. And in my mind, we want to build a new system that is aligned with the healthcare system, that is built around the needs of our residents, our seniors, and that engages the family in a respectful way and a supportive way, that values them as a part of the circle of care, that is an environment in which people want to live, but is also an environment in which people want to work. And the sooner we can do that, I think we all collectively have to continue to hold all levels of government accountable for making sure that happen, then the better it will be. But what we can't do is, we had the Premier of Ontario, and actually the Premier of every province, and the Prime Minister out there saying, we're going to do whatever it takes to protect our seniors and fix this system. And we need to make sure that that's what they do. But we also have to make sure that we don't get diverted by shiny objects that actually don't solve the root problems and could be more disruptive, especially when you look at this from an economic perspective, and what the capacity of governments writ large, given the economic impact of COVID-19, will have to actually fix things. It's going to require partnerships with private and public sector.
Yeah, I mean, there's certainly, I think in Ontario, there's been some banding about like nationalizing the long-term care system by a particular political party, but I don't think that's necessarily a workable solution for a variety of reasons, both on the way that the system operates and the way that the government needs to be involved. But I do, aside from that little aside, I want to kind of build on something you mentioned there, which was accountability of it. It's one of those things where knowing that we had such a surge and such a spike in cases, it's almost hard to remember sometimes that the pandemic is still ongoing and there's still a very real capacity that we're not out of the woods yet, that a second wave could come and a serious second wave at that. How do you ensure that accountability happens in the immediate term and those measures are taken in the immediate term and not just in the long term? Is this something where we need more in the way of inspections, more in the way of oversight, or is this something where long-term care homes now have sort of had a chance to calibrate and get this right moving forwards, so that we can focus on some of the more long-term systemic issues?
I do think that we need to look at accountability, but accountability for what? And how do we focus on quality and quality improvement? There were a lot of inspections that happened between January and today. Labor inspections. There were investigations into complaints throughout this. There were public health inspections. There were fire inspections. Long-term care is subject to a lot of inspections, and unfortunately, what we were up against was looking at compliance against what the law says, as opposed to how do we make sure that we're ensuring the health and safety of our residents? And how do we create a culture where it's okay to say, I need help? Because that was a bit of a challenge, a culture of fear. So, in the shorter term, I think in my mind, because of the new relationships with our hospital partners and local communities around the province, which didn't really exist before this, I do believe that we're in a better space. There's more trust, there's more support, and I do believe that there's a greater sense of shared accountability in this. Our challenge is that we know what we needed to do to get out ahead of a second wave. Our concern, quite honestly, is in the 80% of the homes where there were no deaths, those staff work so hard. Like, they're tired, they're exhausted. We're certainly recognizing in many cases they may have their kids going back to school. That might impact them and their ability to continue to stay at work. We still have thousands of employees sitting at home for a number of reasons. We've got to find a way to bring people back. We need to continue to partner with hospitals. We need to partner with our union partners. We need our labor partners to help us get people back to work and feel safe at work. And that needs to be a partnership, and that needs to be anchored in trust. And we need, but it has to be a shared accountability. When we know that we have these structural historic problems, to put it on the shoulders of a 61-bed home in a rural community where they're doing the best they can, where, and at the outset of this, we knew that there was a PPE shortage, personal protective equipment. We knew that there were test shortages. And at the beginning, we were all working to support the hospitals. So I think we all share in this. Nobody got this perfect. There was no perfect anywhere in the world. But how do we do better? And that's going to be not blaming people, because again, the enemy in this is this invisible virus. Let's make sure that we're focused on keeping people safe and uniting to come together to make sure that this never happens again. But fighting and trying to blame is actually not going to help us.
You mentioned one thing in that answer there that I thought was that we haven't touched upon yet, which is particularly interesting to me as we think about not just long-term care today and the sort of next steps that need to happen immediately, but as we go to build new beds and new capacity in the future. And that's the difference in different parts of the province, right? Between rural and urban locations or Southern Ontario to Northern Ontario. Can you just speak a bit to what the difference in challenge is for some of those potential builds outside of major urban centers, or how they have to deal with the virus in a way that maybe urban centers have it differently? I can imagine that there's quite a lot of variation in scope among the different types of homes across the province.
In many cases, the small and rural and northern homes have a different opportunity in that there is a greater sense of community around them. In many, while you may be dealing with distance in the north and lack of staffing resources, and staffing shortages are significant issues in rural and northern communities, it's very difficult to find a nurse who works locally and can support you, which creates enormous challenges for these homes. Certainly in a lot of the rural communities, and that's where we had our 3 and 4 bed homes. So they're small homes. So what is the capacity to operate a home, even in the short term, if you've cut the number of people who are in the beds by half, because that has a huge economic impact on the viability of that home? How do we make sure that we continue to build for scale within a local community and make sure that people in a local community have access to the care they need? And we could look at hybrid models. Certainly those campus models come into play. What do partnerships look like? Again, I think that, ideally we want people to stay at home longer, but recognize that people can't. But we do want people to be able to stay close to home as well as they age and need more and more supports. Where we saw some of the greatest losses in these tragic losses were in the urban centers. Even in those early cases where we had the first impact in long-term care, I look at Bob Cajun. Bob Cajun wrapped around that home. The college stepped up and was helping us to finance family care teams. The local communities and restaurants brought food. There was a real wraparound, and you can see even today over the last summer months, they were having concerts in support of Bob Cajun, in support of long-term care. In urban centers, these are more anonymous. People don't necessarily know the person who runs their local long-term care home up in York region or in Etobicoke. And that anonymity, I in my own mind, I think that contributed to some of the issues.
Yeah, that's a really fascinating point about the way that these different communities handle these challenges, right? I grew up in a small town, and I always joked that I knew my neighbors growing up, and when I moved to Toronto and lived in an apartment complex, I'd never met them before. You really do struggle with that lack of community. But in building those, so the challenge that seems to be here as you move to new builds in rural communities is that the population density just obviously isn't the same. And so if you now, as you mentioned, you need more space for fewer patients, that business case doesn't really add up. So, are there steps that you could take to try to mitigate some of those challenges? Are there, you mentioned campuses of care, partnerships with local hospitals or other institutions, maybe sort of multiple different types of care in one place. Can you just expand on what that sort of suite of options is for those smaller communities?
Yeah, and I think we need to look at the size of the long-term care home. There's certainly literature that would speak to much smaller homes. So do we need to be looking at smaller homes in those communities? Certainly financing will always be an issue, and we do need to partner with government to look at how do we make these sustainable. Certainly, so as we look at the models, let's look different. The way that Ontario long-term care homes have been built, it's been more of a cookie cutter approach where we have these buildings that have been around since the 1970s, and then we got a funding model and squeezed whatever care we could out of it. So I do think that there's an opportunity to look at who's actually in the long-term care and what are we building around their needs. And so again, not being as prescriptive, but looking for more customization in local communities, looking at the size of the homes, look at how they're going to be staffed, looking for those shared care models with hospitals and primary care and others, looking at where technology can fit in. So we may not be able to have as many doctors or nurses, but can we use virtual care, digitally enabled care to support them? And that then will also inform the infrastructure within the care home. What does your pharmacy model look like? Again, building out more digitally enabled supports. So those may well become greater anchors for those smaller communities. Though therein also lies the challenge that making sure that they have bandwidth and can access technology.
Yeah, and on that note, right, whether it's broadband infrastructure or just putting up more money to help fund rural homes in a different way than perhaps the funding model works for urban homes. I mean, I think I always used to say something along the lines of, if it's a political priority for you, you might as well prove it. And so at some point, government will have to make a choice and an investment to put money where its mouth is on that. So I do want to ask, because I think that leads to a good sort of closing question for you on the episode here is, obviously there are going to be decisions that need to be made, decisions by home operators, decisions by government, all different levels of government, as you mentioned. But if you were speaking to the province today, to decision makers in the different political parties or in the government bureaucracy of the provincial government through this conversation, what are the key takeaways that you think that people need to realize about the situation in long-term care and how to fix it? So if you were speaking to government, sort of what would the kind of message of today be that you would want to leave them with?
Mitch, I always describe this because I've been in the long-term care sector for just over a year now, and so brought some fresh eyes to it. And I liken it to being built like Jenga. And so here's a system that has been built with, one piece of policy or one little funding envelope, or, either being put on top or being pulled out. And no one's actually taken a holistic look at what is a system, and how do we step back and get government to look at this more as a jigsaw puzzle. So you've got something that's coherent and it's anchored by a vision and a shared vision about how the pieces actually need to fit together in a way that they lock in and can create a clear platform and foundation for the care for the people that we're actually there to serve. And, when I talk to people, they don't know what long-term care is. And one of the challenges at the very outset, when there were articles saying, take your loved ones out of long-term care, who are these people? You should just pull them out. There wasn't a recognition, to your earlier question, about the level of complexity of their care needs. The fact that 80% of them are not mobile or have advanced stage dementia, enormous cognitive decline, with not a recognition of the fact that these are the ALC patients who could not go home. And I found that quite shocking, because even hospital folks were saying to me, well, Donna, we canceled our elective surgeries. And I think that we need to have a discussion about what long-term care is. And we all need to come to a common understanding about what those needs are. And we need to be realistic about the need for a shared commitment to build for the people who need long-term care or longer term care, and actually look at it in the context of the care continuum, but also recognize that this is a longer stay. These are not acute care hospitals where the objective is to have the bed empty within 24 hours or less in a very clinically oriented space. And I think that's, in my mind, one of the discussions we have to have is who's living in long-term care, what are their needs, and how are we going to build a system around care for them. And a system, by definition, means that there's interdependence, and that we're all kind of working together in lockstep and are committed to the care, instead of saying that's long-term care's fault, that's the operator's fault. Let's move beyond fault. Let's use this obstacle as the opportunity. Let's leverage it, but let's not let go of it. Because as I said, over the next 13 years, the population in Ontario over the age of 80 is going to double. So let's not lose this moment. Let's build the capital and make sure that we're not cookie cutter. We're being innovative. We're making sure that we've got solutions for rural and northern, as well as City of Toronto. Let's make sure that we're building a workforce that has the skills and competencies to support the needs of the residents who are there. And let's make sure that we're resourcing it properly, and that we all contribute, and that we look at how the pieces fit together with our hospitals and primary care providers. There's been we've had a lot of lessons learned, and I wouldn't want to lose those. And we've experienced some incremental progress that if we just keep building on that and not settling, that I do think we're going to achieve something quite powerful if we hold each other accountable, but also own our own accountability in it.
Yeah, I mean, the way, I think you mentioned it earlier in the conversation, but the way that I would phrase it is it's unfortunate that it had to be something like this in a pandemic that opened our eyes. But now that they're open, let's do something about it, right? And hopefully, today in this conversation, which we appreciate you coming on the program and giving thorough answers and spending the time, and it's obviously a busy schedule given everything that's happening in the sector. But hopefully today we managed to have a start to that conversation and got through to some of the right voices to be able to continue to have it. So, Donna, really appreciate you coming on the program today.
Well, we really appreciate this opportunity. It's an important discussion, and it's one that I care passionately about. So thank you very much, Mitch, and congratulations to your own podcast. It's a great initiative.
Thank you for listening to Intended Consequences, the official podcast of the Strategy Corps Institute of Public Policy and Economy, produced by Sarah Bordeaux and myself. Views expressed during this podcast are not necessarily the views of Strategy Corp. All rights to this episode are reserved, and guests on the podcast may be current or past clients of Strategy Corp. To find out more about the Institute and to subscribe to our written material, or to find past episodes of the podcast, please visit our website at www.strategycorp.com/institute. Until next time, I'm Mitch Davidson.